So, our next speaker and last speaker of the day, I know I've really run you guys through the ringer today. I apologize, but I think it's been a lot of really, really good information. I hope you think so too. Our last speaker of the day is Dr. Michael Uszler. Did I say that right?
Uszler.
Uszler. Sorry. He's the medical director at Santa Monica Imaging and Therapy Associates Incorporated, courtesy staff physician in nuclear medicine at Santa Monica UCLA Medical Center, and assistant clinical professor of medical and molecular pharmacology at UCLA. Dr. Uszler has been actively involved in Spect imaging of all body areas for 20 years, with a particular focus on the brain since 1992. So he's your Spect scan guy, and let's give him a hand.
How do I go forward on this? Just
I always just click right here.
okay. All right. Hello to you. Thanks for sticking around. It's been a long day already. I suggest, how about if you all just stand up and just feel free just to loosen up a little bit, and we won't pass the basket or anything. We'll just okay, next time. You don't have to genuflect either when you come in. It's just all right. So I want to talk about looking at brain function, and I'm going to introduce some other terms in here. So up until now, you're used to hearing about medical imaging procedures such as CAT scan and MRI, which are great at looking at anatomy, and they don't tell you anything about brain function. So the thought is, well, if something has impacted the brain, and the brain, whether it's direct or indirect, how do you know whether the brain is working or not properly? And so where you're using various sorts of imaging, and in this day and age, people have switched from terminology of just calling it diagnostic scanning or what have you, because we're really using elements that are working at the cellular level. Someone decided to call some of this molecular imaging, because we're actually looking at the molecules. We're looking at in vivo biochemistry. So I entitled this sort of looking at clinical conditions and behavior from the inside out, because particularly in the world of autism, the diagnosis of autism is made based upon the behavior patterns that are observed. And that's a good way to do that. And now, in this day and age, we also have technology that we can look right inside the brain and see what's going on in there. So it seems to make, to me at least, makes sense to combine looking at the behavior as well as what are regions of the brain actually doing. And I want you to just think about, it's just some distinctions. I'm going to put out a lot of stuff. It's later in the day. I just want you to kind of like take in, notice some take-home points over here, just sample some ideas. One of the things in terms of imaging, although it's called diagnostic imaging, quite frankly, especially in the world of functional imaging, we're really looking at evaluation. In other words, diagnosis technically means that a scan or an x-ray or what have you tells that a specific disease is occurring. And the answer is, it usually doesn't do that. In other words, something that's abnormal on the chest x-ray is not inherently specific for cancer or not for cancer, or on a brain scan. So the idea is, if we're looking at the function of the brain, we're really doing some sort of an evaluation. We may not come to one specific diagnosis. That doesn't mean the test's not worthwhile. It's just a question of, just as Dr. Rajani was showing you, is that sometimes you do testing and it doesn't give you one specific answer. It gives you a variety of functional information, and you have to look at that in relation to what's going on clinically in that person to see what that particular abnormal function or test result means. And I just said is that molecular imaging basically means we're using medical imaging techniques. We're using intravenously injected radioisotope tracers that actually interact with the biochemistry going on inside the cells. So this is really at the level of cellular and molecular imaging. And it's being used for a variety of things, which includes infection, which includes Lyme disease, And the question is, does the person have Lyme disease? And we're talking about brain imaging today. So you may have a diagnosis of Lyme disease that doesn't necessarily mean your brain is directly affected by that. And then there's various inflammatory conditions that are associated with this. We're using molecular imaging also to deal with people who have had exposure to toxic substances, and of course those who've had stroke and trauma and a variety of other things. And the acronyms that are out there for this type of imaging technology are Spect, PET, PET-CT, or MR spectroscopy, and obviously time doesn't permit us to talk about all these things today. The most common clinical application is in the world of using Spect technology, and most of the imaging I'll show you today is Spect technology. And for once, I'll just say it for all of your benefit, single photon emission computed tomography, that's Spect. And now you know why we say Spect, PET, and just label them that way. So when we're thinking about autism, by now you know that this is really an organic brain dysfunction. It's a neurological problem. It's not just a behavioral problem. And then we can use function imaging as the imaging choice because in most of the people with autism, they have normal MRI scans. And yet 100% of them have abnormal function. So it makes, to me, perfect sense to do functional imaging and not just anatomic imaging. And that autism itself is as a medical condition. Here's one of the take-home points that I see in using this, is that we're not using SPECT imaging to make the diagnosis of autism. We've already said that's a clinical analysis. And the scan itself in autism is going to be abnormal because there's abnormal function in all of these individuals. So the question that I think is that I've learned, and I've been scanning individuals with autism for now about 10 years or so, what I find is that I think is clinically most helpful is we know that this person has some abnormal function, and are there other co-occurring or what are known as comorbidity conditions that are also going on and which is complicating the presentation of autism or the therapy of that. And some of those co-occurring comorbid conditions are ADHD patterns, post-traumatic stress disorder, there's various anxiety disorders, seizure disorders, and there's also some underlying trauma that is usually present in these individuals. For instance, it's like even just in autism in general, there's an underlying element of about at least 30% of these individuals have underlying seizure disorder that is not necessarily clinically apparent. Maybe we'll see something on a scan that'll give us a clue about that. In fact, we can. Just to make you aware, we know that the brain is just 2 to 3% of your body weight, but it uses a lot of oxygen and blood flow. Most people don't know how soft the brain is. It's like soft butter, and it's inside a hard shell, and it's fairly easy to damage that by taking just accelerative injury. In other words, your brain is tightly packed inside here, but there's a little fluid around it. And if you just take like a 2 or 3 pound soft butter, and if you throw that up against a wall, it will deform. Well, if your head is accelerated and you got 2 or 3 pounds of brain mass moving and it bounces off the inside of your skull, your brain gets deformed and it gets injured in that process. Now, it doesn't necessarily cause such a gross deformity of your brain that doing an MRI shows any abnormality, but those cells and the connections between the cells get impacted and some of them get injured. And sometimes that injury pattern lasts for more than a year or several years. And yes, there's other ways to injure your brain, whether it's environmental toxins, recreational drugs, which are common in our society, and even after some other things which are good, coronary artery surgery, and even people who've recovered from effective chemotherapy for cancer, those substances impact the brain and result sometimes in long-term brain function, and it makes sense to use brain function imaging to find out about that. So we're going to talk primarily about SPECT brain function imaging and its relationship to other medical imaging. and then I'm going to show you some cases today about this. So just as a simple review, we're not going through all the details. For looking at the anatomy of your brain, we're going to use MRI or CAT scanning. If we want to see how your brain is functioning, we're going to use Spect imaging or PET imaging. Just another reminder is when we're looking at function, we're looking at function for whatever caused that function or the abnormal function. We're not just trying to make one diagnosis. Now it's an old CAT scan, so this is anatomy imaging. But the key question from this, and the reason why I haven't changed the slide because the question is still the same, if you put a modern MRI up there or a modern CAT scan, the question is, how is this brain working, even if the anatomy looks good? Well, the answer is this brain wasn't working at all. This was somebody who just was post-mortem. We put them in the CAT scanner, took a CAT scan. The brain still looked okay, but this person had no brain function at all. So when you look at a CAT scan and an MRI, they're wonderful studies, and we can see all sorts of detail, but it doesn't tell you how the brain is working. So you have to do some functional imaging. And when we do that with Spect technology, we're injecting some radioisotope material, and we're, again, as I said, we're looking at the biochemistry that's going on in the cells, and that this is objective information when we look at a scan. The way it's done is that the person gets an intravenous injection of some radioisotope substance. We know how to use these things. They've been around 20 years. Give an intravenous injection, and the stuff goes right to your brain within about 2 minutes. And the substances stick inside your brain. Now, they go to regions of your brain in relation to how well the blood flow of the brain is to that area and how those cells are working. This stuff actually goes into the cells, and it happens to be by a mechanism that involves glutathione, changes the tracer so that it sticks in the cells. And so we can take our time doing imaging. It also means that if you have individuals who, and I scan a number of kids with autism and cerebral palsy, they can't cooperate in the scanner. They can't hold their head still for 10 or 15 minutes. Now, the interesting thing is that because the tracer sticks in the brain for a couple of hours, and because the administration of sedation doesn't change that distribution pattern, we can get a good scan of even people who can't cooperate and who can be scanned by using sedation. And this is the way we've done a lot of these studies. We inject the children in the most quiescent state that they can be, and only after it's time for scanning do we actually apply any sedation. So the child sleeps during the scan, wakes up 5 minutes later, but we got a physiologically meaningful scan on that person. This is what a Spect scanner looks like. It has, the person's head is here. You're laying out on this imaging table, so it's not as confining as an MRI system or being in some tube. There are multiple imaging heads that slowly rotate around the patient's head. In essence, the isotope goes all throughout your brain. We've got systems that gather three-dimensional information. The whole volume of your brain is gathered. And once it's in the computer system, then we can slice it, dice it, and look at it in a variety of ways. And I'll show you some examples of that. And the usual example that you'll see in a lot of literature is that there'll be a lot of grayscale slices through the brain. Now, once you get used to looking at these, it's pretty easy, but what I'm showing you on the next couple of slides, this is a transition, taking you from looking at the slice information to bringing it into a pattern of three-dimensional information such that you could look at the brain on one slide from 6 projections and you get it. And you don't have to figure out what's on all these little smoke rings. Now, for the purpose of example, I picked somebody who's grossly abnormal. This is somebody who had a stroke so that you can see specific abnormality. Now, I can see that there's a difference from this side to this side and from this side to this side. And yes, we've used color scales. This is the same information and just in different color scales. And of course, there's a multitude of color scales out there that are used. They don't necessarily mean something specific. The purpose over here is to say this person who had this huge insult to the right side of their brain is not working. This is a person who's got a stroke, and so the left side of their body is very weak. The left arm, the left leg aren't moving. That means something impacted the right side of the cerebral cortex in this person. And by convention on this color scale, black is bad. And good uptake is over here in the brown to yellow range. And when you get way toward the top of the scale, that's almost overactive. The purpose is this person had a stroke, so in the right side of their brain, in the motor cortex area, black is bad. That part of their brain isn't working. Areas around it, the so-called ischemic penumbra, are at a lower functional level, but they're not necessarily dead. So I just want you to get a sense that we can transition back to looking at three-dimensional volumes of information, albeit it's in a two-dimensional format. And we've seen this. This is the same person with a stroke pattern. Here's a child who was pulled from the bottom of a swimming pool. It's a near, so-called near drowning case. And remember, the uptake over here is supposed to be, none of this is supposed to be in the green or in the blue. And so this is diffuse brain injury, diffusely decreased functioning brain of this child. And here's a child with cerebral palsy. There's no one pattern with cerebral palsy. They're all quite different. But in this child, huge portions of this child's brain are in the blue and black zone, aren't working well at all. We also, I have and others have a database comparison. In other words, right now what I've showed you are images, and it's my experience and my gut sense of what's going on. But because this is all digital data and it's all quantitative, we can, and because we could gather a group, just like they do in laboratory testing, as Dr. Vajani just showed you, is you have a group of normals or some reference database comparison. So if we got a group of people whom we thought were normal, scanned them, made a database out of that, and then when the next person comes along and patient, we match up like, how does that person compare to 20 people in that same age range, and map that out on the screen. The concept is that if that person matched those 20 representative samples, then their brain scan would just look all gray, because this is the 2 standard deviation reference range. And if in that person, areas of their brain were not working as well as that reference population, then we color code them in green and blue in terms of standard deviations. Again, the concept is blue and black is bad. And if you're up in the red zone, those areas are actually functioning at a level that's higher than any reference population. Point I want you to just take home on is that in these individuals, we're going to find all sorts of patterns. Yeah, amongst autism, there's areas of the brain that are underactive and areas of the brain that are overactive. And so it's helpful from the standpoint of therapy to know the extent of that and what areas of the brain are affected and to what degree. Now, to keep it simple again, rather than show all these color scales, but I just wanted to make you aware of that, I'm going to show you some cases. But the simple application is this, is that if we simply reduce this now to just looking at the surface of the brain and without any tricky color scales, we just have grayscale imaging. In other words, if in the normal circumstance, the pattern, whether you're looking at the front of the brain, the back of the brain, looking at it from the top or looking at it from down below, basically things ought to be pretty uniform throughout the brain, should be pretty smooth, pretty uniform. Just notice this pattern. You're going to see this slide again in comparison with some cases. So that under normal circumstances, most areas of the brain are functioning within a certain range and it's pretty uniform. There shouldn't be parts of the brain missing function. Now, before I show you some of them, and because I speak also at the hyperbaric sessions, many people say, well, is every brain scan, especially SPECT scan, clinically useful? Now, I see SPECT scans from all across the country, and I used to not comment upon this very much, but I can tell you there's not a uniform level of quality of SPECT scan imaging across the country. So not all SPECT scans are useful, primarily because in many places they don't really know how to do them with sufficient detail, and or they interpret them without understanding the clinical context of brain dysfunction. In other words, most places, most radiology departments don't do brain function imaging on children, period, because it's tough to do that. Or if they do that, they're not used to thinking about how would brain function look in somebody with autism. So the point is that if you're going to get a SPECT scan, you need to find out if these places actually have experience doing it, and if they really know how to interpret the scan in the clinical context of autism or of Lyme disease, for that matter. And if you have a question about it, you can contact me. I'm willing to talk to various imaging groups out there to find out what they're really doing to help you know whether or not you can get a good SPECT scan in different parts of the country. And this is just a quick example of a scan that was sent to me. It's overprocessed. There's inadequate detail. This scan was read out as being unremarkable in a person who obviously had some brain dysfunction that had some head injury. And the way that I know that is they sent me the raw data and allowed me to reprocess the data. And what you find out is if you really know how to look for this, guess what? Remember what that normal looked like? Nice and uniform? Well, this is not a uniform brain. Now, this brain does not have holes in it, okay? The MRI scan, the anatomy scan of this person looks completely normal, but these are function patterns. So what this says is that this part of the frontal lobe, this part of the frontal lobe over here, these parts of the temporal lobes, which should be nice and uniform over here, there's large areas of function that are below the expected range in somebody who has an abnormal anatomy pattern. This is good to know. Most people think that if you get your bell rung, you get a little concussion, nothing happens to your brain. Well, guess what? It does. Now, this happened to be somebody who's been working in a refinery and is exposed to various chemicals and has been losing function on the job. He's got a normal MRI. Well, the answer is if you really do a brain function scan on, you find out why this guy is malfunctioning on the job, because he's got large areas of his brain that aren't working very well. Here's their normal again, remember? Nice and uniform, temporal lobes are there, everything's filled in. Whoops, can't go backward on this system, huh? Okay, we can only go forward, all right. Now, just to bring this into real life, you know, this is reality TV and everything else or what have you. I'm going to show you an example of scans on 3 people, a mother and 2 of her daughters. They're in the audience this evening. They visited with me, had some scans just a couple of days ago. Because I want to give you some sense of like how we're using these scans to help in the evaluation and understanding of what's going on in people. Whether or not there's the question of Lyme disease or autism. These happen to be individuals. 2 of the daughters over here are certainly somewhere along the spectrum. And I'm just going to show you what we saw in these individuals. And I'm going to speak this as gently as I can. This is the mother. Now remember, it's supposed to be nice and uniform, filled in. The blue arrows are just saying, look, there's large areas of the top of this person's frontal lobe, temporal lobes over here, lots of areas of decreased function. MRI was not done, but it's probably normal because this is not brain damage. This is brain anatomy that's there, but it's functioning poorly. Why is this person, this mother, having difficulty with a family that has children in the autism spectrum, and why is she having some difficulties? It's because parts of her brain aren't working well. Now, this doesn't mean that she's on the spectrum or what have you. She's not. She and both of her daughters are clinically confirmed as Lyme disease. Now, in my experience, I've never seen Lyme disease do something this bad. In other words, this is pretty extensive findings over here. And whether we look at it in this scale or if we look at it in this blue is bad scale, in other words, these are the same areas, it's another way of showing dysfunction over there, is that the question is that this is worse than what I've seen with most Lyme disease cases. So which usually looks like this. This is an example of somebody who has chronic Lyme disease. So this is like a completely separate individual from this mother and two daughters. But the idea is that there's small areas of this decreased function, but it's usually not as extensive as, can I go the other way? Yes, I can. It's usually not as extensive as this. So when I talked with this mother subsequently, I said, well, what else is going on? In other words, the purpose of the scan is to say there's areas of decreased function. What could this mean? What other things could be going on that could cause this? Because we want to help this person. We want to use functional imaging to help them as much as possible, rather than just to put a label on this and say this is Lyme disease or it's not Lyme disease. So one of the things we've learned in terms of using brain function imaging into the world of behavioral medicine and psychiatry and what have you, is that this is neurologic information, neurologic function information, and there's a lot of things, because the brain is very soft and vulnerable, that can impact the brain function. And the purpose is, and please understand, I did get the clearance of the people about whom we're talking, so I'm speaking about this because I want to deliver a message of hope over here. And the idea is that other things probably contributed to this pattern. And so when I talked with the mother after the scan, yes, she has Lyme disease, but she had some head injury. She's also had some mercury toxicity. She's also had some pesticide exposure. Now, until you see some of these scans, you don't stop to think about some of these things that could also have effect on a person, so that you can appreciate what could be various causative factors over here, and that could cause you to think, what are we going to do to help this person? Now, some of this may be some Lyme disease involvement in the brain, but there's something else that impacted over here. There's some, very likely there's trauma, other toxic factors, and I'm going to make a case for also using some hyperbaric oxygen to help these people along. So we've seen this slide. This is one of the daughters. Now notice there aren't much of an abnormality over here. It's just a little bit in the temporal lobe, just something in the top of the brain over here. Looks pretty good, and this child is functioning quite well. That sort of fits. But if we really compare it with a database, well, quite frankly, there's more of those blue areas that are going on in here in this person's brain. Now, question was, well, if this person is functioning reasonably well, but she's positive for Lyme disease, is this all neuroborreliosis, Lyme affecting the brain? Well, again, let's stop and ask some questions. What else has happened? These people who have Lyme disease aren't living in a vacuum. They're exposed to things and what have you. So I said, well, what else could this be? There's no pesticide exposure, apparently. There's no toxic substance exposure. So, oh, by the way, could there be any trauma in this person? Remember, the brain's soft, trauma injures. Some of those injury patterns can last for months and even years, and we're just beginning to understand these things. Could this, in the temporal lobes over here, be some traumatic effect? Well, she didn't really ever have any trauma. except that when I probed a little bit, and some of us have learned, Dan Amon, who does a lot of brain function imaging, he and I know each other, and so one of the things we've certainly learned about is that most people dismissed brain trauma. Like they got their bell rung, but it doesn't mean anything. Or you got knocked out and you had a concussion, but like it didn't have any effect on you. Guess what? It does. And most people just deny that they had head trauma. So you got to ask 1, 2, 3, 4, 5 times to find out if there was ever any trauma history in this person. And so as I was discussing this with them and sort of persisting in my questioning, well, as it turns out, this person did happen to be in a car accident, but they didn't really hit their head. However, this person ended up with a broken jaw. Now, I got to tell you, in order to break your jaw, which is a pretty strong bone, somehow you got to whack yourself pretty good. So you got to know that this head had to be moving, and maybe only the jaw hit and not the top of the brain over here, but 2 or 3 pounds of brain matter went whack. And parts of the brain low down like this, what I call the temporal lobes, sit inside of bony ridges. The inside of the skull isn't smooth. There's some sharp ridges in there, and you accelerate the brain, you can rip things and you can shear parts of the things in there. This doesn't mean permanent brain damage anyway. Remember, this is a message of hope, but it's a message of sort of looking at what's real here. Why is this person having some difficulty? Well, she's got parts of her brain that aren't working very well. What can we do to help this? Well, I'm going to make a case for some hyperbarics to be part of the process of helping this. And there's some areas, however, of her brain that are not only underactive, but some areas that are overactive. We know that in the basal ganglia, if they're overactive, this person usually has a lot of difficulty with anxiety-like behavior. And this pattern of hot frontal lobes and the cingulate gyrus and the basal ganglia fits with post-traumatic stress disorder. Again, I want you to get the idea. We can look at the scan, see concurrent other things that are going on so that we better understand and help how to come up with treatments that address all the issues that are going on over here, not just one diagnosis. Now, here's the other daughter. And she's a charming young lady. I met her just the other day. And really a happy person. She's definitely in the spectrum. But I got to tell you, I've seen hundreds, probably, I don't know, maybe, it must be more than 1,000 children with autism. This is way beyond what you see with the standard autism pattern, okay? Usually with ASD, you see some decrease in the temporal lobes and some decrease in the cerebellum, but you don't see this kind of stuff where large areas of the frontal lobes have just dropped out function. So the question becomes, well, what else has happened that has impacted the brain function of this very delightful individual? So we get back into asking ourselves questions of like, has there been, in addition to that, some episodes of trauma? Apparently not. Has been any exposure to any toxic substances? Apparently not. But at least we can start asking questions and looking to see, well, what else does this mean? What else could this be? Is there something that's being missed here while the person is being helped with their behavior patterns and while they're being helped with their Lyme disorder? And you don't necessarily, and I can tell you from having seen scans for a number of years, you can't predict from looking at the behavior of this person just what all the functional patterns are in a person's brain. Now, I want to make a case for the fact is that this sort of thing ultimately helps you to get a sense of like, this young lady really needs some help over here. We got to do whatever we can to help her along. Am I seeing a question? Where this is?
Correct me if I'm wrong. Are you defining brain function as circulation of isotope and localization of the spikes? How do you define brain function?
Well, it's based brain. The question is, how do we define brain function? And we're defining brain function over here as the fact that a tracer is injected and it gets to the brain not just because of blood flow. It's a tracer that goes through the blood flow and gets into the neurons and is taken up by the neurons in relation to how they're really working. Well, the isotope happens to be called Seratech. Well, it localizes in all areas of the brain in relation to how those cells are working, at what level they're working. The basic idea is that the better the function, the more the uptake. The higher the function, the greater will be the amount of uptake in any part of the brain. The question is this independent of circulation? The answer is it's not completely independent of this. Maybe let's just step back over here and just say, for 20 years now we've been doing nuclear cardiology. What does that have to do with this? The answer is the principle is the same, and that is the way that we see how the heart muscle is working. With problems of coronary artery diseases, we use tracers that go through the blood flow, so it is blood flow dependent, and gets into the cells in relation to how they're working. So this is really cellular function imaging. Now remember, this person's probably going to have a normal MRI, but there's large areas of the brain that are really not functioning very well. Whether we use this approach or whether we use a database comparison and see that there's areas over here that are clearly not functioning very well. Now, in contrast to her sister, who had a whole lot of increased activity over here, this person has a whole lot of decrease. In other words, all the cortex over here around the surface of the brain should be at least in this yellow to brown coloring, and there's areas that are below that. So this young lady doesn't have the overactive patterns in certain parts of the brain. She's got underactive patterns. Maybe we ought to use some different medications, some different forms of therapy combined to help her with the whole pattern of how we can integrate things and help her brain to work better. So this is a take-home message. Is there hope over here? Well, my experience, I've been scanning the people who've had hyperbaric oxygen therapy before and after therapy for at least 15 years. And so there is hope. Hyperbarics doesn't solve all the problems. Standard applications that have been around for years are diving accidents, carbon monoxide exposure, and it's only within about the last 5 to 10 years that hyperbaric oxygen has been pushed into the more controversial areas of using it to help cerebral palsy. We know we can help these people get better. We know that children who have autism can get improved function with hyperbaric oxygen therapy. We know that, and I've seen cases where there's severe near drowning episodes and the child comes in literally in a wheelchair, just barely able to functioning in a vegetative state, gets some hyperbaric therapy over a period of several months' time, and gets remarkable brain recovery such that they come walking back in. I've seen this in adults, I've seen this in stroke patients. And yes, the Spect scan gets better, and I can show you examples of that, but time doesn't permit. I just wanted to give you a take-home message over here. You can do something if you've got some brain injury. And this is an example of it. Now, this is the same stroke patient. This is the one I showed you before. Left side of the body's weak, got this hole in the right side of the brain, except that she doesn't have a hole in the right side of her brain. This is her scan before she had hyperbaric therapy. This is the scan after hyperbaric therapy. This is a 20-year-old person, not a 70-year-old person. She was in a car accident, tore her right middle cerebral artery, ends up with the equivalent of a stroke. She's 20 years old. Her life, she was a college student, her life just has gone to pot because she's weak on one side of her body and has a lot of brain dysfunction, because everybody focused on the fact that she had the equivalent of a stroke over here, and nobody thought about the fact that maybe other parts of her brain, like other areas of her brain and on the other side of her brain, weren't working very well. Now, she came to hyperbaric therapy 2 years after the accident, and all sorts of OT and PT and what have you. One of the things hyperbarics can help people even years down the line after the impact of whatever damaged their brain. Now, would you think she could recover? Well, this area that was the stroke, this is after 40 hyperbaric treatments, this area of her brain is probably dead. Okay, it's not going to recover. But the area around the stroke got better. But what's more important is that parts of her frontal lobes improved function. This part of her brain, the left side of her brain, got a whole lot of improved function on the scan. This is objective evidence that her brain function is improving. And the good news about it, and part of the message of hope is that Elena, having struggled with this for 2 years, she's now had about 100 hyperbaric oxygen treatments. She's now about 23, 24. She's still has some weakness on the left side of her body. The only difference was hyperbaric oxygen therapy in her. And she learned how to go back to school. So she could go back to class. She completed her college degree. She learned how to drive again. She got a job. And she got married, and she got her life back. It's like, this stuff works. We don't necessarily know all how it works, but I'll tell you, it works. And here's the message of hope about somebody who's diagnosed with Lyme disease. Notice there's a lot of blue areas over here. And this person, this is before hyperbaric oxygen therapy. This is after she had antibiotics and hyperbaric oxygen therapy. There's less blue area. She's not completely better yet, but we're making progress. This is over, there's about a 6-month time difference over here. So that areas of the brain that are dysfunctional by a combination of therapy, not just hyperbaric oxygen therapy, even with Lyme disease, you can improve your brain function. That's the message of hope here. So, in summary, we're looking at the function of brain cells, not just their anatomy patterns, that using technology like Spect gives us an objective comparison because we can compare it with a database. Mind you, I've got a built-in database in my mind, but it's not the same as in the next 3 imaging doctors' minds, But having an objective database, we can compare to the same sort of reference population. That we can look for smaller degrees of regional change. We can do before and after comparisons because we've got the data, can process it through the same quantitative system. Again, the take-home message I think that's important is that no matter what you're thinking about clinically, this reveals various comorbidity, co-occurring other conditions that are making the situation worse and which would stimulate you to think about what combination of therapies would we need to be most effective in helping anybody. And yes, it does provide objective evidence. I don't promote this, but I know that I'm told by parents and people in the hyperbarics world is that even if their treatment for their disease or for the scan or what have you was not covered by insurance, and this is a common story for those of you who are dealing with autism. If you put down the word autism on something like this, the insurance company immediately is going to say, denied, not covering this, not paying for anything. Well, I know that, and I've been told this, that if you get some objective evidence of a couple of Spect scans getting better, parents have told me that they've subsequently gotten retroactive reimbursement for therapies and for scans because you got an objective piece of evidence over here that's pretty darn hard to deny. You put up one of these slides over here, a brain function, like 4 foot by 6 foot, most people get the message that something is going on over here and something has changed. And if you believe what we're doing with the color scales and the database, something's getting better. So in completion, I'm going to say thank you for using your brain function during this presentation.